Now let's look at some key functional issues and at EHRs in other settings. We previously mentioned that there were issues with electronic clinical quality measures, or ECQMs. Here we are going to look at the specifics. ECQMs are provided by CMS for many of their reporting requirements, but issues such as different submission methods for different programs remains troublesome. The American Medical Informatics Association observes that providers generally lack faith in the accuracy and completeness of ECQMs, and especially those requiring data from other systems than their EHR. EHR vendors are putting resources into overcoming issues with ECQM reporting functions to the detriment of some other customer priorities. CMS did conduct a pilot study on ECQMs and found that most EHRs were capable of collecting required data, but there were two other key issues. Data mapping issues from the source EHR to the Quality Reporting Document Architecture, QRDA, were largely due to data residing in free text notes, dictation, and scanned documents rather than discrete data fields that had to be manually entered into the Quality Reporting Document Architecture. Although this is largely due to clinicians attempting to overcome usability and functionality issues with EHRs, as we just discussed, and not the CQMs or QRDA system, it was also found that EHR vendors need more time to address these issues as updates occur, and hospitals need time to incorporate them into clinical data entry practices. Also, clinical workflows and terminology did not align with ECQM specification. Many data elements are documented in more than one location during normal clinical workflow. For example, differences in latest time a patient left the emergency department ranged from 5 minutes to 4.25 hours based on older generation, order placement, order authentication, patient leaving the ED, patient placed in a bed. Greater specification may be needed to overcome some of these issues, but also more clarity within the EHR as to which data point is required for which ECQM. In general, hospitals are seeing some improvement in ECQMs as CMS is providing more education, ability to test ECQMs with the hospital EHR before production, validation tools that data reported in the QRDA files are accurate, and regularly timed updates to ECQMs so changes can be programmed into EHRs and rolled out. CMS is also reducing the number of measures required to be reported. In addition to these needs relative to current ECQM processing, hospitals want to be able to use quality data to improve care, hence have the ability to pull data as entered into the QRDA into their own data warehouse and knowing that it is the same as what CMS has. Hospitals also want to be able to use the EHR for clinical decision support with respect to the ECQM results, again requiring the ability to perform analytics on the ECQM data and incorporate those into appropriate e-tools. In general, EHRs are either minimally used, much less refined, or significantly different in design in most other care settings. Their ability to be used to earn Medicare or Medicare meaningful use incentives has influenced their uptake. Let's take a look at some of these. Specialty providers, neurosurgeons, oncologists, nephrologists, and many others generally must use a generic EHR with specialty templates, but workflows for certain specialty data and workflows are often needed. Chiropractics, dentists, optometrists, and podiatrists were eligible for Medicare meaningful use incentives, but many are not Medicare providers and hence were reluctant to invest in EHRs. As such, data sharing with them is challenged. Behavioral health EHRs exist, but only psychiatrists with doctoral degrees qualified for Medicare meaningful use incentives, and their numbers are so small that each one tends to be contracted by several different entities. Hence, they do not have the volume of patients at any one facility necessary for meaningful use. They are further challenged by the fact that they are potentially required to learn several different EHR vendor systems. Other behavioral health specialists are starting to use EHRs, but often believe their clients are not comfortable with EHR, although there is evidence that client use is actually beneficial. Behavioral health and primary care data integration is probably the highest need when considering EHRs in other settings, and behavioral health vendors recognize this, but actual data sharing is often stymied by privacy concerns. Long-term and post-acute care, including nursing homes and home health agencies, have information systems for some of their data collection required for reimbursement under CMS programs, but lack standards to support interoperability. Retail clinics, occupational health services, pharmacies, durable medical equipment, DME vendors, correctional facilities, community health centers, federally qualified health centers, and many other providers do not all have the volume of services provided by eligible professionals for Medicare meaningful use, though under Medicaid meaningful use, nurse practitioners, nurse midwives, and certain physician assistants do qualify. EHR design requirements vary in these entities, with some extensively used and others very limited in use. Public health, human services agencies such as transport services and Meals on Wheels, assisted living centers, police and fire departments, and other similar entities are not generally considered providers of health care and are challenged not only with funding an EHR, should one exist for their environment, but with privacy regulations that make providers reluctant to share data with them. Still, in a value-based care environment, more sharing of at least limited data with these agencies would be beneficial. For example, transport services have need for understanding the general nature of a person's disability. Meals on Wheels should know of dietary restrictions, and police are finding they are sometimes the first line of defense in severe addiction situations. The ability to share data across these very disparate platforms is extremely challenging. One standards development organization has established a registry for specialty functional profiles to promote a common set of functionality for EHRs within a given specialty area. But the profiles rely upon specialty associations or societies for their creation and maintenance. Other standards development organizations, whether for technical or semantic interoperability, have provided limited support for data sharing for special types of healthcare facilities.